Well, welcome back to the Depths of Healthcare. I'm your host, Ben Imes, here with Dr. Frank. Dr. Frank, I'm just going to call you that. We didn't actually chat about me calling you that, but I apologize if that's offensive.
No, it's fine. I don't.
Why don't you introduce yourself to my listeners and kind of give us a little background on who you are?
Oh, no worries. So my name is Dr. Frank Okosun. I'm an board certified internal medicine physician. I'm in private practice in Lake Jackson, Texas. It's a suburban area about an hour south of Houston. So I've been in practice for over 20 years now. Private practice 11 of those 20 years. Internal medicine, that's what I live and breathe for. I enjoy it. I love complicated cases. I love to solve puzzles. I love to solve riddles. So I'm pretty passionate about what.
And when you started practicing, internal medicine is a very broad scope, and my listeners probably don't aren't aware of kind of where you can go with that when you graduate residency or a fellowship if you specialize. So, did you kind of start as a hospitalist based medicine? Did you start as a primary care? Did you kind of find a fusion between that?
So I actually did both, which is called, I started off with both, which is called kind of like a traditional practice.
Okay.
So I see patients in the clinic, but when my patients are hospitalized, I follow them in the hospital.
That's like
So
19.
yes, that is correct. That is correct. It's rare, and you don't see a lot of people doing that right now. I don't do that currently. It's one of the quickest ways to get burnt out. I did it for a while. I don't do it. I don't do it currently. I love, like you said, internal medicine is very wide, and that is what I love about it. Because initially during residency, I tried to do different rotations in different specialties and all that, but I couldn't really narrow it down. I just loved everything. So I love that anticipation. I might go into one room, I'm dealing with somebody with anxiety, depression. I go into another room with somebody with hyperthyroidism. I go into another room with somebody with uncontrolled diabetes, A1C of 14. So I like the variety, and it makes me have to think on my feet and multitask and make things happen. Yeah, I couldn't see myself just dealing in one specialty and just wake up every day and only do
Yep.
one thing.
I totally get that.
That would be very, very, very boring.
No, I get the same thing. I mean, I actually worked orthopedics for a little while, and it's the same process for every knee that you take care of.
Yes, yes, yes,
And,
yes.
sometimes you get an exciting one where they get infected, and then it's like, maybe
Eh,
it's infected, maybe it's not. But there's only three things to do. You take an x-ray, you do an injection, or you get an MRI.
that is correct. So after a while, to me, it's just kind of monotonous. It's like you're just going through the motions.
Yeah,
I like that excitement. I
totally.
love, like I said, I love puzzles. I love riddles. So a lot of the like nurse practitioners, the PAs, and family medicine patients in my region, they know I love complicated cases and
Cool.
all that. So when they get a very complicated patient, they were like, "Don't worry, I got the guy just for you who will figure you out." And then they
So after what I'm hearing is that you kind of transitioned away from that traditional style kind of clinic where you followed your own patients and then started your own practice. Is that correct? Where you kind of started taking on these more complex patients?
not quite. So my journey was after leaving residency, I worked a hospital employed position for 2 years. There I was in a traditional practice model. So I follow my patients in the hospital and then see them in clinic. I'll see them in clinic after their discharge or when they are
Right,
stable.
right.
But I just didn't feel comfortable answering to a CEO with a marketing degree because they don't have the medical background. To them, patients are just numbers. Oh, you got to see more patients. Oh, you got to be productive. Oh, you got to do this. You got to do that. You're not a team player. And I am somebody, I like to be very thorough. I'm not one of those doctors who come in and say, hey, you got 5 minutes, one problem. If you got another problem, you got to make another appointment. That's not me. I sit down and take the time, make sure I go over everything thoroughly, make sure the patients understand their options. We come up with a plan. Everybody's clear on the plan. So that takes a little bit of an extra time. But because for them it's a numbers and metrics game, you're considered not a team player because you're not going fast enough. But unfortunately, if you go too fast and make a mistake, and that's your license on the line, and they won't be there to help you. There are two things that are very, very important to me: my personal reputation and patient safety. Those are two things that I don't compromise under any condition.
Right.
On Monday, I got a surprise in the mail. Are you familiar with the Castle Connolly recognition?
Tell me more about it.
Okay, so Castle Connolly, it's a company that designates top doctors and top hospitals and top facilities in the
Mhm.
United States. They've
Okay.
been doing that for 50 years now. That is the highest, most respected recognition for doctors and hospitals in the United States. Doctors who have that recognition are considered in the top 7 percentile nationally in their specialty or in their field. So the recognition, you can't pay for it. It's not all these other
Good.
the awards that you pay for and get a plaque or whatever.
Right.
Your patients can nominate you, your staff can nominate you, your friends or family can nominate you. You have to be nominated by your peers,
Wow.
doctors, colleagues who know your work and who respect what you bring to the table. So when you're nominated, you have to go through a rigorous vetting process where they look
Wow.
at your education, your certification, look at your license history, see if you have any malpractice issue, and then you are awarded that um, recognition. And like I said, that recognition signifies that you are in the top 7% nationally
Wow.
in physicians in your specialty. So I got
Did
that
you
surprise.
receive that this week?
I got that surprise in the mail on Monday. So I'm the only primary care physician in my county who has ever won it and who has won it for 2 consecutive years now.
Wow.
So I
Congratulations.
don't compromise with my integrity and my name. I've worked very hard to attain that level. So I'm not going to let any CEO or anybody try to rush me or push me into doing something that I wasn't comfortable with, or rushing through patients. The way I like to describe it is kind of like a car. When you're driving a car at 60 miles an hour, you can't compare the kind of control you're going to have over that car going at 60 miles an hour over one going at 120 miles or 150 miles,
Right.
50 miles an hour. So I decided after that to go open my own practice. So I started from scratch, zero patients. And gradually, I
Brick and
built it.
mortar? Like you started from scratch, like, just rent
I
the
hung my
space and see what
shingle.
happens?
I hung my shingle. I registered my company, and I got going from zero patients.
Wow.
So this was about 11 years ago. And obviously, it took time because you have to, especially when you're in a new area, you have to build trust.
Right.
You have to earn it. It just doesn't come automatically. And gradually, word of mouth, referrals from specialty physicians and other physicians, I gradually grew the practice to about 4,000 patients that I have,
You have 4,000 patients, not all managed by you.
all managed by me. That's correct.
Oh my gosh. How how do you do that?
I know it's very busy, and that was one of the reasons why. So when I started the practice, I was still following my patients in the hospital. But
Yeah.
after about 3, 4 years, I just saw that it wasn't sustainable
Right.
because it's busy, busy, busy. I might go home at 9 o'clock, at 2 o'clock in the morning. The ER physician is calling me with an admission. It has interrupted my sleep. He has interrupted my wife sleeps. Sometimes they might call me. My patient is in a code blue. I gotta get ready, drive, go to the hospital. I gotta go on Christmas Day. I gotta go on the weekends. I gotta go
Yeah,
every
nobody
day.
that's burnout
So
central,
yeah,
recipe
yeah,
for
yeah,
disaster.
yeah. So I did it for about 5 years. I mean, initially, while I built up the practice, it was one of the ways to generate leads and referrals. When you see patients in the hospitals, emergency room physicians know you and they refer patients to you. So it was a great way to build up my practice. But when I
Right.
got busy and got going, yeah, I
You're
knew
like,
I
"Cut
knew
that
it
off."
wasn't sustainable. Um, Thankfully, my hospital had a great, or they still have a great hospitalist program. So when the hospitalist medical director approached me, they actually approached me and said, "Hey, Frank, Because I think at one point they were kind of having some low censuses.
Mm.
So the hospitalist medical director approached me and said, "Hey, Frank, do you want us to help you out with your hospitalized patients?" I was like, "Take it and run, move."
Not that you don't care. Like, I want to make sure the listeners, it's not that Dr. Okosun doesn't care for his patients. He absolutely does. It's just a workload he didn't need to have.
Yes, and also, like I said, one of the things I like to do is make sure my patients are safe and they are getting the best care. I don't want to be bogged down in clinic and something emergent is happening with my patient in the hospital, and they're having to wait for me to drive over there or finish what I'm doing to go over there. So the
Right.
hospitalists, they are in-house 24/7. They are right there and they can jump on any issue
And
as
if they really need you, they can reach out at a more non-emergent time, you know?
that is correct. The only difference is the patient suffers a little bit on the continuity of care aspect because these patients have been following me for a while, so I kind of already know their history. A lot of
Right.
these patients, I don't need to open their charts. I already know what's going on with them. But with the hospitalists, they don't really know. They're meeting the patient for the first time, and really they are laser focused on the acute issue that the patient is in the hospital for, which is fine. But sometimes that acute issue is tied in with some other issues, and not having that knowledge sometimes it's a little bit of a disadvantage
Yeah,
to the
and if you
patient.
can't track everything down, obviously, in our very fragmented EMR systems, this
Yeah,
clinic uses
yeah,
this other clinic uses Epic, somebody else uses Cerner, you have to kind of track down the whole regimen of their whole medical history, and you might miss something.
yeah. And hospitalists too, they are busy now. They're having to see 25, 30 patients a
Oh
day.
yeah, yeah,
So they have to move pretty quickly. So
right,
sometimes they call me and they ask me questions because, like you said, no matter how robust your EMR system is, you can't document everything about a patient. There are certain things about the patient that only the primary care physician would know. You can read those charts for 1 year. You're not going to have that. You're not going to have that information on that
right.
patient. Yeah.
So what I'm also understanding is that for when you open your own practice, it sounds almost like you're trending. I mean, I don't know if you accept insurance or do cash pay only, but you reserve more time is what I'm hearing. Maybe an hour, 45 minutes per appointment or something
That
like
that
that.
is correct. Yeah, so I currently accept insurances and also see patients who don't have insurance. I offer them a cash pay discount. So technically, although I spend a lot of time with patients, I don't literally reserve an hour for or 30 minutes for patients because with the declining insurance reimbursements and cost of inflation has gone up, you have to rent is more expensive, you have, staff pay is more expensive, equipment and stuff that you're using is more expensive. But unfortunately, with the insurance reimbursements, they're going down. And with
You're
that, it means
preaching to the choir.
you, yeah. So you have to, and I guess we'll get to this again at another point because I'm in a process of another transition because of this reason. So you have to see more and more and more patients to keep the lights on.
Keep your margin.
Yeah, yeah, yeah. So typically, a private practice physician will tell you that when you see 20 patients a day, when you see when you see 12 patients a day, you've paid your staff. When you see 20 patients a day, you've paid your overhead. You don't get paid until you see 25 to 30 patients a day. So with those number of patients, there are only so many hours in a day. So
Yeah,
you have to double book, triple book, and all that. And unfortunately, some of these patients require some more time. And like I said, I'm not one of those guys who will come in and say, "Hey, 5 minutes, one problem. If you got more than one problem, you gotta make another appointment."
right.
So it's becoming more and more difficult to do that because unfortunately the line is backing up. So people now are having to wait an hour and a half, 2 hours because I'm trying to be thorough and listen to everybody and not miss anything and make sure
Right.
everybody's on the same page. So sometimes patients, some are very understanding because when it gets to their turn, they see how I spend enough time with them. Or some are upset. Hey, I had a 10 o'clock appointment. It's 11:30. What's going on?
Mhm.
And because of course, some people try to come on their lunch break or they have
Right.
other things to do. So it's getting more and more and more and more difficult
Yeah.
to stay on track with that.
What are your workarounds? Like, how do you kind of find your way to solving that issue?
Not having a lunch break, need to stay an hour or sometimes two afterwards.
Yeah.
But like I said, with the hospitalist thing, I've come to find out it's not sustainable. So if I reduce my patient load, then I'm not going to be able to cover my overhead and keep the lights on. I can't go against my personal ethics and cut every patient down to 2 minutes, one problem, because that's just not my style. So
Right.
that's why now I'm in a transition now to a model that focuses more on prevention and wellness. So I will get to see less patients, be able to spend quality time with them, and then also be able to focus more on prevention and being proactive on wellness instead of reactive sick care, waiting for things to break down before you jump in and try to do things. So I'm currently in the transition to that process and I'm very excited.
Yeah. I mean, so, for the listener's sake, what you're doing, excuse me, what you're doing is the anti-American medicine at this point is transitioning away from the reactive care, "Oh, you've been this way for so long, let's throw medications at it," versus now you're considering transitioning more towards that preventive style of, "Hey, let's approach your diet first, approach your lifestyle and your activity first, rather than having to just throw medications at every single problem, because that's the easy fix, that's the Band-Aid."
For sure. And I actually take it a step further.
Go ahead.
So in my program, all my patients once a year, they're going to get an executive level physical from head to toe. Yeah. So they're going to get their eyes checked. They're going to get a hearing test. They're going to get an EKG to check their heart. They're going to get a pulmonary function test. They're going to get a ABI or ankle brachial index done. They're going to get a advanced lipid profile uh, that is sent to the Cleveland Heart Lab. You know, Cleveland is number one in the US for
So they're
heart
gonna
issue.
get apoprotein B ApoBs and
You got
lipoprotein.
it. There's a test that we do that's called myeloperoxidase oxidase activity. So that tells us the state of the if they have plaque in their blood vessels, the state of that plaque, and it tells us
Stable versus unstable, basically.
you got it. So with those tests, I can predict fairly accurately a patient who's going to have a heart attack in 5 years or a stroke in 10 years. And
Mhm.
then we can jump on it right now and prevent it.
Yeah.
And then we also do a lot of inflammation tests. So we do high sensitive C-reactive protein. That tells us if there's any inflammation in the endothelium of the blood vessels. And then we can jump on it right now because the studies are showing there are two main drivers of cardiovascular disease right now: inflammation, high sensitive C reactive proteins, and diabetes. I'm sure you
Mm.
know diabetes is a
Oh, yeah.
coronary artery or stroke equivalent.
Break down a little bit more the inflammation bubble because most of us understand diabetes as being a risk factor for
Yes,
cardiovascular disease, but
yes.
how, I mean, is it inflammation from a diet, inflammation from work stress, life stress, lack of sleep, or is it a combination of all the above?
It's a combination of all the above. So what I noticed a couple years ago is, like I said, I told you I see
Yeah.
complicated patients.
Yeah.
So I have a lot of patients who have a lot of autoimmune diseases.
That's where I was
Diseases,
tracking.
okay. Diseases like rheumatoid arthritis, psoriasis, Crohn's disease, and all these other autoimmune problems. And I started noticing a very common pattern among them. About 80% or 90% of them all had coronary artery disease. And
Mm.
some of these patients, they were fairly young. They didn't have diabetes. They didn't smoke. Some of them were not obese. And they had very significant coronary artery disease where some of them had to have bypasses. Some of them had multiple stents. So I began to notice that the common denominator with them was the inflammation.
Mhm.
So inflammation from their disease. So the rheumatoid arthritis inflammation, the Crohn's disease inflammation is not just affecting the joints and the GI
Mhm.
system. It's also affecting their blood vessels,
Yeah, the vasculature as
causing
well.
So it's affecting their blood vessels, causing a lot of inflammation. And with the inflammation, that increases the risk of a plaque rupture and strokes and cardiovascular disease.
Hmm.
And obviously, like you said, stress, high cortisol levels, high adrenaline, noradrenaline levels, eating a lot of processed foods. So what we typically preach now is you want to eat a plant. You don't want to eat something made in a plant. We focus more on plant-based. So you don't want to eat a lot of processed foods and things
Right.
like that because all the foods are very pro-inflammatory. So one of the dietitians I work very closely with, what she tells her patient, if you go to the store, make sure you read the food label. If it has more than one ingredient, drop it and look for something else.
I mean, that's the best way to do it. But go to
Yes,
any
yes.
grocery store, major grocery store chain. I You're lucky if you find one of those. You're lucky if you find one
Yeah, yeah,
ingredient.
yeah. So I tell my patients, I'm like, if you want to eat, yes. So I tell them, if you want to do right or you want to be very proactive about your health, shopping is going to take you about 45 minutes to an hour instead of just 10 minutes. You can't just order it through the app and drive up into the parking lot and pick it up. You have to actually go in the store and actually read labels. You can't go into Publix or Walmart and say, hey, what's on sale today? Baby back ribs, 9.99. No, I tell them you can't shop in the front of the store because in the front of the store is where all the
Yep.
bad stuff is.
Yep.
The candy, the cakes, the baby back ribs, and all that. You're not supposed to buy anything from the front of the store. You have to go inside the store, and then you have to go there. You got to read food labels. You have to spend.
So this transition is going to become much more, I would say, educational. I mean, it's not you're going to be much more doing what you're doing right now of explaining a lot of the pathology and the pathophysiology behind these different illnesses and but also you have to get very creative, I'm sure. So it still keeps you very stimulated, I'm hoping, because you got to deal with all these systems as you create a plan moving forward.
That is correct. So after I do that extensive physical, we also do a extensive skin exam with
Mm,
a dermatoscope to make sure that there are no lesions that we need to worry about. So after all this extensive testing is done, we get back all the results from Cleveland Heart Lab.
mhm,
So I sit down with the patients, and like you said, it takes me about an hour and a half, and I go over everything line by
mhm,
come up with a wellness plan that's tailored to them on what we need to do to fix those issues that we found. So diet, exercise, nutrition, stress management, sleep,
mhm.
sexual health, mental health, all the good stuff. Then from that testing, if we find anything wrong and we need to send them to a specialist, we already know what we are sending them sending them there for. So if we do the pure tone audiometry and we find out that they have a hearing problem, we're sending them to a audiologist or an ENT with a specific reason. We're not sending them because right now, because we don't have time. If somebody comes in, oh, if knee hurts, orthopedic, chest hurts, cardiologist, you got a spot on your skin, dermatologist. So you're not really having time to really go into detail and really
Right.
find out what is going on. And patients, they hate that. It's upset. They're like, oh, I thought I'm going to see a doctor. This doctor now is sending me to 8 other different doctors. 70 to 80% of all patient issues can actually be managed in
Yep.
primary care.
Yep.
But unfortunately, there's not the time. And you don't want to be in a situation where you miss something. So because there's no time to listen to the patient. There's no time to properly examine the patient. So what ends up happening is you order more tests that might be medically necessary just because you don't have the time and then you don't want to miss anything. Or you send the patient to a specialist for them to go figure it out. So that way it's like CYA. You're covering
Mhm,
yourself. Hey,
mhm.
you had an ear problem. I sent it to an ENT. Let them go figure it out.
Not my
So by the
problem.
time yeah, not your problem. So by the time we finish the executive level physical, we already know what the problem is. If it's an abnormal ABI, we're sending them to a interventional radiologist or a cardiologist. They already know that this patient has abnormal ABIs, probably have an occluded blood vessels in their
Yep.
lower extremity.
Yep.
They already know what to do. So I'm not sending them to for them to figure it out. It's
It's
sending
for
them,
intervention's sake.
yes. So before it gets to the point where the patient has a gangrenous foot and the foot
Yeah.
has to be cut off and all that,
Mhm.
we can intervene early and get it fixed.
And so that's where you want your patient population to kind of trend so that you're catching things ahead of time, but also preventing further things as you continue to follow them throughout the year.
That is correct.
Yeah.
So my goal is I want to keep them out of hospitals. I want to keep them developing chronic diseases
Right.
that they will have for the rest of their lives. Prevention is always easier and better than cure. So I'm all about prevention. Like you said, I'm not just all about throwing medicines at patients. I like puzzles. I like riddles. I like to get to the underlying cause, figure out what that is and fix that instead of just putting band-aid on problems and keeping it moving.
Yeah, because we've all taken care of those patients who have 18 comorbidities and are here for something pretty high, see us for something high risk. And
Yes.
we can cure that high risk thing, but it will affect every medication or allergy that they have downstream or affect, oh, she's in a CHF exacerbation, but, you know, she's already already has major kidney damage. And so, like, what do we do at that point? These different things.
Yes. And that is where you need a good primary care or internal
Totally.
medicine doctor to come into the picture. Because I like to call primary care, we're kind of like the quarterbacks of the team. And we take a holistic approach in evaluating patients. When you send somebody to like you just said, send somebody to a cardiologist for a CHF exacerbation, the most common thing in residency and all medical professionals do is cardiologists, what they say, what they preach about is if somebody's in a CHF exacerbation, hit them with Lasix till the creatinine bumps. When the creatinine bumps, you know their volume stable at that point and then you figure out the rest of. The nephrologists are fighting the cardiologists. They're like, no, we don't want the creatinine to bump up. So everybody is kind of laser focused on their own system and
Yep.
issue,
Yep.
and they are not looking at the patient as a whole.
Right.
And because these patients go to a lot of specialists, and like you said, electronic medical records don't talk,
Mhm.
there's an increased potential for them to be on medications that will interact or have side effects. I can't tell you how many times I've seen patients who are on metoprolol and carvedilol. They get it for two separate doctors. I've seen patients who are on bumetanide from their nephrologist and they are on Lasix from their cardiologist. So they are just on NSAIDs when they have kidney problems. The
All the
whole,
things we
the
were
whole,
taught not to do.
yeah, because like I said, the electronic medical records systems don't talk.
Right.
Sometimes we don't get records from other doctors. Sometimes we get the records. We just take a brief glance at it. We don't really have time to really review it, and then things get lost in translation and transition, and then
Yeah.
patients have bad outcomes.
And so, I mean, this is a big deal, like, across medicine, and you're doing your part is what I'm hearing. How difficult has it been to kinda transition, like, over your career into this point now, like, as a business owner as well? Obviously, we haven't even touched on the business owner side of things where you're doing your own roofing, you're keeping the lights on
Yeah.
yourself, right? But,
Yes.
I mean,
Yes.
is this a
Yes.
potential where you don't have to see that 25 to 30 a day where you can actually cover yourself and maybe even take home a check?
Yeah, definitely. Yeah, definitely. So the goal under this program is I will see an average of about 8 to 10 patients a day.
Awesome.
Because what's going to happen is that 4,000 patient panel, I'm going to narrow it down to about 300 patients. And with those 300 patients, I'll be able to follow them longitudinally and be able to get to know them on a very deep and personalized level. So with those smaller patient panels, I'm not rushed for time. I can really spend the time to get to know them and get to the root causes of whatever is going on. They will also have access to me after hours. So instead of them going to the, no offense, go to the
I know.
emergency room or urgent care, they can call me. And because I've been seeing them for so long, I can help them triage and say, hey, something I can fix. I can give you advice. I can send medicines in for you. Or no, you need to go to the ER right
Yeah.
now.
Yeah,
Fit
absolutely.
under this model, the research has shown, because a lot of research has been done, research has shown that they are 30% more satisfied with their primary care physicians under this new model. And it has also shown up to a 50% reduce in hospitalizations. Because, like I said, it's not a situation of somebody has an acute CHF exacerbation, they call their primary care physician. The next available appointment is 1 month. You can't wait for a CHF exacerbation for a month. So before you know, they end up going to the ER, they end up
Yeah.
being hospitalized. The CHF exacerbation hospitalization on average can be 3 5 days, and that's easily a $25,000 hospital bill.
Right.
So this system has been shown to reduce hospitalizations, save the insurance and the healthcare system a lot of money from these reduced hospitalizations and reduced ER visits. Because, like I said, if a lot of these conditions can be prevented or caught early, then they can be properly managed. So if you have a patient with CHF and they call me and say, "Hey, Dr. Frank, I've noticed over the last 3 4 days, I've gained an extra 5 6 pounds." I'm going to be like, "Hey, what's going on?
Mm,
What's your fluid intake like? You know what? Double your Lasix for the next 3 days and call me back and tell me where you're at."
yeah.
So instead of them continuing around that on that pattern where over a week or 2 weeks they've gained 20 pounds and now it's a full blown CHF exacerbation. Now
Right.
they now have to go to the hospital and spend 5 6 days. And you know, with hospitals, how that works. You go in with one thing, you come out with another. You go in for CHF exacerbation before you know you have a hospital acquired pneumonia. Or before
Hmm.
you know you've developed a decubitus ulcer or a catheter associated urinary tract infection.
You've
So
got an
you
infectious diarrhea, whatever it may be.
have CD for whatever,
Hmm.
or COVID or whatever they got going on in the hospitals. So you go in for one problem before you know you've developed 3 4 problems. Now instead
And
of
then there's a readmission.
there's not only a readmission, or there could be a chance of them actually having increased mortality from because
Right.
they were already there with underlying comorbid conditions. Maybe they had ejection fraction of 10. They had end-stage COPD. They were on oxygen. They had chronic liver disease. So having all those multiple comorbidities already puts you at an increased risk for mortality. So when you have a significant pneumonia on top of those underlying conditions, or you have a severe C. diff infection, or you have a pyelonephritis or a urosepsis, risk for mortality goes through the
Skyrockets.
roof. Yeah. So if you do make it out the hospital alive, the mobility you might come out in bad shape. So guess what? Instead of going back home, now you got to go to a rehab facility for 1 month, or you have to go to a nursing home facility for 1 month to go get PT, OT, and rehab to get back to your original baseline. And being in a rehab facility too, you can develop different things over there. The cubitus also, UTIs, pneumonia, and all that. So before you know, it's a recurring revolving door, and you're costing the system money. You're not having a good quality of life and all that. But unfortunately, the insurance companies and the government, they don't want to adequately reimburse primary care, because unfortunately the American healthcare system is procedure driven. You are not paid for the hour it takes you to talk to a patient and figure out their medications and figure out a regimen that will work for them. But if I take the patient to the cath lab, I'm making $5,000. So they don't reward the intellectual and the mental
Correct.
energy that goes into keeping these patients safe and in good health. So they reward procedural
Hmm.
abilities. Hospitals now focus on procedures. So they want
Yep.
to keep their,
Because that's what
no
keep
offense
their
to
lights
you,
on.
no offense to you, they want to keep their orthopedic surgeons happy. They want to keep their neurosurgeons happy. They want to keep their invasive interventional cardiologists
Hmm.
happy. And all they rely on us as primary care is just referrals downstream to those specialists.
Right.
New folks or younger folks now going into medical school, of course, student loans have ballooned over the last over the last 20, 30 years.
Right.
People don't want to go into primary care where they might barely make 200 or 250,000. Everybody wants to go into dermatology, orthopedic, plastic surgery,
Right.
neurology, neurosurgery, because of course they want a better return on their investment. So
Totally.
unfortunately, primary care is grossly underfunded.
Mhm.
And I've been waiting for a while, thinking that it's going to get better. The government, the insurance companies, somebody's going to do something about it. But I've come to find out there's no help on the way.
You gotta do it
So
yourself.
I have to do what I have to do. And
Yeah.
I have given it more thought, a lot of thought. It took me about 5 years to make this decision
Mhm.
because I started to feel for my patients. I'm like, okay, what of some of my patients who are not able to afford this
Right.
service?
Right.
Unfortunately, all this testing I'm doing is not covered by insurance.
And you probably have to negotiate, like, contract deals or whatever for these different labs
Yeah,
that
yeah,
you're.
yeah, yeah, yeah. Yeah, yeah, yeah. So those tests I'm doing are not covered by insurance because they are considered not medically necessary or experimental or what of that. So the patient has to come out of pocket for that. So I've been thinking, oh, what are my patients who can afford it, who are struggling and all that. But I was like, it's not getting better, and I can't continue to provide 30 to 40% quality of care to a
Mhm.
thousand people when I can provide 100% quality of the care to 200 or 300 people. Because like I told you, I hold myself to a very high standard. I don't compromise patients' safety or my own professional integrity. And I was just like, hey, something has to give. So that is why I'm transitioning to this new model where I have the time and the resources to adequately take care of my patients and listen to
Right.
them, be there at their time of need. And now too, I will also have time when they're admitted and they let me know they're admitted. I can go visit them in the hospital. I don't necessarily have to be the admitting physician, but I can go visit them. Seeing a reassuring face is kind of like a placebo effect, already
Mm.
makes them feel better. I can address any concerns they have. I can talk to the hospitalist, answer any questions they have, understand the plan, make sure the patient has a follow up when they're discharged to come see me in a timely manner. And they can be great continuity of care because I really missed going to the hospital. But with increased documentation requirements in the hospital where you have to do it used to be you have to do a HMP, you have 24 hours to do a HMP.
Yep.
And then I think they
It's way
brought it
less than
down.
that now.
There was a time I heard they brought it down to 4 hours, and then I heard they brought it down to an hour in a critical patient. I can't be seeing patient in the clinic and leave those patients there to go do a HMP in the
No way.
hospitals. So it's not sustainable. So those patients have to be seen by the hospitalist team. But that way I can be kept in the loop and know what I need to follow up on, why the patient was there, if there are any referrals or follow up with specialists that they need, I can help coordinate that, and it's a seamless transition. So I'm very, very, very excited with I can't wait to get started under this new model
And
because
that's
this
imminent?
model of practice, I'm sorry.
Is it imminently
Yes,
starting?
it's pretty imminent. So I've started a transition and I go live with the program at the end of May. So it's a 3 month transition because with this program, we're going to be the first one doing it in our region. It's
Very
a
cool.
national program that has a network of about 1,500 doctors in the network already. The program has been in existence for 25 years,
Oh, okay. Okay,
but they
cool.
tend to be they tend to be in like high density, high
Yeah.
income
Yep.
cities and
More
sites
niche.
sites
More
of
niche and, yeah.
Yes. Like I told you, I'm in a suburban area about an hour away from Houston. So when you're trying to describe it to patients, they don't just get it just like that. They're like, what do you mean? So we want to make sure in this 3 month transition that we are able to educate our patients exactly what this program is about and exactly the benefits to them because unfortunately, especially this era of social media, there's a lot of misinformation going around. There have been rumors on social media that I've done some bad things. I'm about to get into trouble, arrested. That's why I'm switching to this model. There are rumors going around
Wow.
that I've been bought out by hospital systems and private equity and all that. That's why I'm moving to this model, which is not true. I still 100% own my practice. It's still me. When they come,
Mhm.
they will see me. See, no offense to you, they will see a PA or a nurse practitioner. Is they see me, my staff is still there.
Still with you.
So yes, and then there are people have carried rumors that hey, when you go to this program, you can't use your insurance anymore. He's not going to be contracted with insurance, which is totally false information. So that's why we have the 3 month period to constantly continue to educate these patients so that they can make an informed decision on
Right.
what they want to, if they want to join the program or if they don't. Like I said, we just want to make sure that they have the right information so that they can make the right decision because we are filling those spots on a first come, first serve basis. And when we get to our max, it's going to be waiting list space only.
Yeah.
So we don't want patients to dilly-dally or make wrong assumptions. And when they try to come back or call us back, we are already filled. Because I've seen it happen a lot.
Mhm.
Patients always think that the grass is greener on the other side. They've
And then
come
they
and be like,
try
oh,
it and they don't like it and they never show up again.
no, no, no. I'll tell you what has been my experience. So they come and say, oh, why am I waiting 45 minutes? I got work to do. I can't deal with this. Tell my records to this other doctor or I'm not coming back or whatever. And then they go 3, 4 months, they go and all that. Then all of a sudden, so obviously we deactivate their chat since they know they're coming to us. Then all of a sudden, I see a familiar name on the schedule. I'm like, what's this person doing here? I thought they left. So they've gone to other practices and seen that the level and standard of care they get here is not comparable to what is obtainable out there. So they're like, well, I had it good over there. I gotta go back. So they were able to do that. And I'm not like some other doctors who are vindictive and say, hey, you left the practice. Now you're considered a new patient. We're not accepting new patients. You can't. And I've had patients on their way out. They've gone giving me 1 star reviews on Yelp and Google and all this stuff. And then they've come back. And I'm like, okay, if I was so bad that you gave me a 1 star review, why did you come back? There are other doctors and clinics you can go to. So they had the law. So and like I said, some doctors when you do 1 star review or you don't follow what they say, they send you a termination letter and
Yep.
you are gone with it.
Yep.
This week even got more interesting. I saw a patient this week who I hadn't seen for 4 years.
Wow.
This is what happened 4 years ago. She reported me to the Texas Medical Board. And there was an investigation. I mean, it was a big hassle. I had to get a lawyer from
Yeah.
my malpractice.
Needless to say, that's a massive hassle.
Yeah, so I had to get a lawyer from my malpractice
Oh.
insurance company to
Yeah, to
explain the
deal
event.
with it and kinda sort everything out.
Then ultimately, I was cleared. My excuse was she was sick during the COVID period or something. She was short of breath and all that. So she called my office, and then there was an issue of her deductible. I think it was beginning of the year deductible and all that. So she was initially arguing, I don't have a deductible. I have the best insurance. I should only have a $20 copay. And they were like, no, we've checked it on the software. We've called the insurances. No, you have a deductible. This is the amount that is due today. So that was the first argument. She went back and forth with my staff and all that. So she finally agreed. I'm like, okay, I know I have to pay this, but unfortunately I don't have the funds now. Can you put me on a payment plan? Can I just pay $20 or $30 today and then put me on a payment plan to pay the balance off? And we've been burnt many times with that, so we don't do that anymore. So we told her the total payment, full payment is required at the time of service. So she was like, I'm here, I'm short of breath. You won't see me. We're like, ma'am, unfortunately, our policy, you payment is due at the time of service. We're like, okay, if you're short of breath and you're having issues, you can go to the emergency room. So she hung up, and then 1 week later, I got a letter from the Texas Medical Board saying she had complained about this and all that. So she obviously didn't understand the law, and she claimed I abandoned her when
Right.
she was shot right and all that. She doesn't realize that in clinics, I'm not bound by EMTALA.
Right.
Yeah,
Whereas we are.
yeah, the emergency room you are. So she was confused and thought that I was bound by EMTALA, that I had to see her whether she could pay for it or not.
Right.
So, like I said, it was a little bit of a hassle. It was a little bit distressing. I had to get a lawyer from my
Right. Right.
malpractice area. They had to send back an explanation to the medical board. And like I said, at the end of the day, the case, the investigation got dropped. I was cleared because obviously the board has an obligation. Anytime they get a complaint or whatever, they have to
They got to
legally
investigate.
investigate. Yeah. So I was, like I said, ultimately absolved of any wrongdoing. So when that happened, I was just like, okay, I forgot about it and moved on. So like I
Yeah.
said, a lot of doctors will immediately after that send the patient a termination letter. So I just assumed that okay, if you took it so far that you report me to the medical board,
I'm
there's
not going to see
no
you
way you're
again.
coming back. And you won't believe it. 4 years later, I saw her this week.
Wow.
And she was so nice. Oh, it's been a long time. How you doing? Thanks for agreeing to see me. And guess this, she lives an hour, 30 minutes away now. So I'm like, you couldn't find it. So I saw her virtually. So I was like, you couldn't find a doctor thing. The city of Houston, where there are doctors,
Yeah.
5 doctors on every corner. So I was like, you couldn't find any doctor over there. You decided to go back to the doctor you reported to the Texas Medical Board about.
What did she say?
No, I didn't bring it up. She didn't bring it up.
I see. I see. I see.
I kept it professional. I
Sure.
addressed what was the issue that she had. My practice manager after the visit was like, we should send a termination letter. So she actually, I guess, to get my information because I guess she didn't have it all these years. So she Googled my name, and in the process, she found out about the program, and she was asking questions about the program. I kept it very short because I don't think she will be an ideal person for the program, especially with this issue of reporting me to the Texas Medical Board and all that.
Right.
So I don't think she'll be a good fit for the program. So she was asking questions, but I kept it short and I didn't encourage her to enroll or whatever. My practice manager was like, "Oh, let's go ahead and send her the termination." And I was like, "I don't think we really need to do that. We're moving on to this new model, and
Right.
yeah, she will not be a fit. She will not be a fit for it
Yeah.
since our values don't align. She'll be."
Man, I'm excited to see what kind of comes from this transition. I hope my listeners can kind of continue to watch your space. Is there a place where they can kind of
Yeah, yeah,
keep up
yeah.
with
We have had
your clinic's progress and everything?
yes, for sure. So they can follow me on I'm on LinkedIn, Frank Okosun. I have 2 websites. They can follow me on frankokosonmd.com, or they can also Google, it's a longer name, but they can Google Frank Okosun MD VIP, and my second website information will pop up. So, like I said, it took me 5 years to make this decision. So we're initially nervous. Obviously, I'm the primary breadwinner in my household. Well, like we patients want to buy into this model. So we did a survey. We surveyed about 10% of our patient population. We sent them out a survey and said how satisfied they were with their services with us. We were thinking about this program. What do they think about it? Would they be interested? If they're interested, how much are they willing to pay for it? So we're able to get a ballpark figure. So we saw that there was significant interest in the program, and people were willing to pay for it. So that gave us some more confidence in going into the program. And so far, we started enrolling about a week or two ago. We have already exceeded our targets, our anticipated targets. So the enrollment numbers are matching the survey data that we did. And that's why we are trying to make sure we educate these patients fast because like I said, these spots are filling up very fast and it's a
Hmm.
first come, first serve. We can't verbally reserve a spot for you. You have to go through the enrollment process
Right.
and get signed up. So another thing that we're doing in this 3 month window, why it's a little bit longer, because some patients are like, I signed up already. Why can't you start tomorrow? Why can't I start the program tomorrow? So I was like, no, it's a transition process. Like I said, it's an educational experience for a lot of the patients. Some of them will not get the concept on the first go. So sometimes they have to come back again. Sometimes we have to reach out to them. Sometimes they will have more questions that we have to address. And then also to, unfortunately, like I said, because I'm streamlining the panel of patients, there's going to be a lot of patients who are going to have to find new doctors regardless.
Hmm.
Either if they find out the program is not a fit for them or they don't sign up in time to meet the cutoff, they're going to have to find a new doctor anyways. And these are patients who have been following me for a long time. And like I told you, patient safety is of utmost importance to me. So I want to make sure that there's a proper transition of care.
I
We
see.
help them we help them find new doctors. We get their records transferred over. We make sure there's no interruptions in their medications, in their therapies, and all that. So we're strictly emphasizing to them, don't wait till the last minute. You can still see us to the last day of the transition, which will be 3 months from now. You can still see us. It's still business as usual. But don't wait till the last minute because some people are praying that the program doesn't work, and then we'll have to go back to our original
Hmm.
practice that we're doing right now. But I'm sorry to disappoint them with the numbers we're having.
Right.
That's not going to happen. So I don't want them
Understanding your
to.
work.
Yeah, so I don't want them to hang around and then they wait to the last minute and then they try to call somebody they can't be seen for 6 months and then they want to stick up, come back seeing me. It's not going to happen. I gave you 3 months window for you to get your health together. So that's why we have that longer period for the transition to make sure people are educated, make an informed decision on what they want to do. And
Hmm.
then if they decide it fits financially or their personal situation, we can assist them in finding new physicians so that their care is not interrupted.
Yeah. Well, I hope as we watch this space that you guys continue to grow. Obviously, it's I'm sure an exciting but a stressful time all at the same time. But I
For
hope that
sure,
the
for sure.
patients are excited and you're geared up and ready, and your whole staff is ready to get things kicked off. It'll be kind of cool to follow along and see how things are kind of continuing to progress as you transition.
Definitely, we're really excited. Like I said, the response has been phenomenal. We're on average now enrolling 10 people a day. So unfortunately, we're going to fill up
Yeah.
with those 300 spots very quickly. And then other patients who I don't even see have heard about the program for friends and all that. So they technically haven't seen me, but they're already enrolling for the program
Yeah.
too as well.
Yeah.
So people in the community, other people who have heard about it are enrolling. So those spots are gonna go fast. So we're so excited. We can't wait to get started.
Yeah, well, I think at least hopefully this episode these people can listen to, and then maybe even just get more insight, and maybe you'll get filled up sooner than you think.
For sure, we welcome it. Yeah,
Yeah.
we're very excited.
Well, Dr. Okosun, Frank, thanks for your time. I appreciate just even sharing just the whole journey. Honestly, the whole journey. It's been really exciting to highlight you and just to hear how your brain works because I think it's very similar to a lot of our peers.
Yes,
Our
yes.
peers, especially the ones I connect with on LinkedIn and my peers I work with day to day, all feel the same things that you and I are both feeling. And so it's getting our voices out there so everyone else can understand.
Definitely, definitely. And your followers are free to follow me on LinkedIn. I typically post weekly or twice a week.
Okay.
General health education content, diabetes, high blood pressure, obesity, weight loss, diet, exercise, nutrition. So it's a lot of information out there
It's very helpful. Yeah,
to learn from because I feel like the empowered and the knowledgeable patient is the best patient. Yeah.
absolutely.
Don't want patients. When I say jump, you're like, how high are we jumping? No, I want you to understand why we are jumping. I want the patients buy in so that we can work as a team instead of saying, oh, because sometimes I ask patient, oh, why are you doing this? You're like, I don't know. The doctor just told me to do it. I'm like, no, no, no. Anything you need to know why you're doing it so that you can buy into that process and not just do it because you're being told to do it.
Exactly. No, well, appreciate your time today. I know it's very valuable, obviously, because you got a lot of patients ready to be seen today, I'm sure.
Thankfully, Friday is kind of like my administrative day. So that's when I catch up on all my paperwork from the week. Because unfortunately, too, paperwork has gone up. I have to fill out paperwork for people for emotional support animals, FMLA,
Yep.
liver abscesses. Yeah, it's a
All the things.
yeah, prior authorization, referrals. So I have to dedicate a full day
Yeah. It
for
makes
all of
sense. It
that.
makes
Yeah.
sense. Well, I hope you get some
So
good rest doing
that's
that.
but unfortunately, all that work on a day like this is unfortunately uncompensated time because, like I said, the insurance doesn't factor in all these other things into the process. But I do it for the patients. I love what I
Yeah. And you it shines through. It shines through that you care for them very much
yeah,
so.
for sure. Because at the end of the day, it should be about the patient. It's not about you. It's not about me. It's not about the middleman, the pharmaceutical companies, or the insurance, or the government. It should be all about the patient.
Yeah, absolutely. Well, that'll be all for today. Thank you for your time. Appreciate you. And
Well, thank you so much for having me. I
yeah,
appreciate it.
I'm glad we got to connect. I think it was a great time.
Yes.
All right, Dr. Frank, you take it easy, man.
Thank you so much, Ben.